Welcome to the Radiology Review podcast, your on-the-go source for radiology education with your host, Dr. Matt Covington, a board-certified radiologist. Please follow the podcast on Twitter at RadRevPodcast. Send emails to theradiologyreview@gmail.com or visit the website theradiologyreview.com.
Welcome back to the Radiology Review podcast. On this episode, I will be talking about lymphoma. This will be part one of a multi-part series on lymphoma board review for radiology board examinations. I've made the decision to discuss lymphoma on the next few episodes due to listener requests. I want to take a moment to thank all of my listeners around the world. I presume that many of you are radiology trainees, but some of you are also either completed with your radiology training or are looking forward to completing radiology training in the future, or perhaps you have another interest in learning more about radiology for other reasons. Either way, I hope you are all safe and well wherever you are amid these ever-changing times. I also want to take a moment to thank each of you in medicine for what you do, whether you are in radiology training, medical school, or a practicing radiologist, or in another capacity. Thank you for all you do. Now let's get into the episode. First question. On imaging, how can we differentiate retroperitoneal fibrosis from lymphoma? Take a moment to consider what the differences are between retroperitoneal fibrosis and lymphoma. Retroperitoneal fibrosis pulls, tethers, and constricts structures inward and medially, whereas lymphoma displaces and surrounds structures by pushing them outward and or laterally without constriction. On imaging, with retroperitoneal fibrosis, you should look for medial tethering of the ureters with ureteral stricturing or narrowing and resultant hydronephrosis, as well as abdominal aortic encasement without deviation. On the other hand, lymphoma pushes things outward, so look for anterior displacement of the abdominal aorta. Look for lateral deviation of the ureters, which may be encased by soft tissue, but importantly, not strictured or narrowed, and you would not expect hydronephrosis with lymphoma. On MRI, retroperitoneal fibrosis would classically be T2 dark due to the fibrotic tissue. Lymphoma on MRI would typically be T2 iso-intense to the spleen. Importantly, both of these can show delayed enhancement on MRI. So to unpack that, a few keys. First of all, lymphoma can have delayed enhancement on MRI, and that would be typical. Retroperitoneal fibrosis pulls things in, constricts, and narrows structures. So you see the ureters getting pulled in, constricted, narrowed. You might see resultant hydronephrosis. On the other hand, lymphoma displaces and pushes things outward without constriction or narrowing. So with lymphoma, you see the aorta pushed anteriorly in the abdomen. You see the ureters pushed laterally, and you do not have ureteral constriction. You do not have hydronephrosis. Next question. What is a classic appearance for renal lymphoma? Renal lymphoma typically presents as bilateral, homogeneous, hypovascular, round and oval circumscribed masses within the renal parenchyma. This has been described as a cannonball appearance. Other less common manifestations of renal lymphoma include smooth renal enlargement or perinephric soft tissue infiltration. With more aggressive lymphomas, you would see infiltrative renal lesions. Most cases of renal lymphoma occur with widespread systemic disease. Primary renal lymphoma is much more rare than secondary renal lymphoma from systemic disease, which would typically be a non-Hodgkin's lymphoma. Renal lymphoma is often clinically asymptomatic, so classic presentation that you might most likely see on the board exam would be the cannonball appearance, where you have bilateral, homogeneous, hypovascular, round and oval circumscribed masses within the renal parenchyma. Next, can you develop primary lymphoma of the urinary bladder? The answer to this is no. There is no lymphoid tissue in the bladder, so lymphoma of the bladder is always secondary. Next question. What is a typical appearance for splenic lymphoma? Most commonly, splenic lymphoma will manifest as diffuse enlargement of the spleen, or splenomegaly, without a discrete lesion or mass. This is most common for a low-grade lymphoma, so most commonly you simply would see splenomegaly with splenic lymphoma. On FDG PET-CT, you would expect splenomegaly with uptake of FDG within the spleen that is higher than that of liver. Higher grade lymphomas involving the spleen may have discrete splenic nodules that would be focally FDG avid. So in the spleen, if you see an enlarged spleen with activity above liver, but no specific mass within the spleen, that would be more classic for a low-grade lymphoma. Once you start seeing FDG avid masses discretely within the spleen, that can be a sign of a higher grade, more aggressive lymphoma. On CT imaging, nodules within the spleen would typically be hypovascular compared to the normal spleen. So you would expect masses from lymphoma to enhance less than normal spleen. Also look for associated lymphadenopathy elsewhere, as splenic lymphoma is typically a manifestation of systemic disease. Next question. What is the most common primary tumor of the spleen that is not lymphoma? The answer is splenic angiosarcoma. Splenic angiosarcoma shows infiltrative masses with internal necrosis and hemorrhage, and it is the most common primary tumor of the spleen that is not lymphoma. Next question. What is the typical imaging appearance for testicular lymphoma? Testicular lymphoma typically appears as homogeneous, hypoechoic, vascular testicular masses that may be indistinguishable from a testicular seminoma. Now, you may have one or more masses, but all of these would typically be homogeneous, hypoechoic, vascular masses similar to a testicular seminoma. Both testicular seminoma and testicular lymphoma appear as homogeneous testicular masses, whereas other testicular tumors are classically heterogeneous. Testicular lymphoma is most commonly a diffuse large B-cell lymphoma and is most common in older males and is frequently bilateral and may involve the epididymis. Lymphoma is the most common testicular tumor in patients over 60 years of age. Seminomas, on the other hand, are usually seen in younger men, maybe in their 30s or so. So a slightly older age for lymphoma compared to seminoma. Both can be indistinguishable on imaging. Next, what is the typical treatment of testicular lymphoma? Testicular lymphoma is typically surgically managed, which is unique for lymphoma, that is typically a non-surgical entity. But with testicular lymphoma, the most common treatment would be surgery with orchiectomy, which is the fancy medical term for testicular removal, orchiectomy. Next question, why is the typical treatment of testicular lymphoma surgical? The answer I am looking for here is that the blood-testis barrier exists, and the blood-testis barrier prevents chemotherapy from reaching the testicles. So you need to surgically remove the testicles in order to eradicate the testicular lymphoma, because typical chemotherapy may not cut it. Beware of the follow-up FDG PET scan for lymphoma that shows that the lymphoma throughout the torso is no longer seen, but testicular activity remains above normal. Sometimes testicular lymphoma is not appreciated on the baseline FDG scan due to the extensive hypermetabolic disease elsewhere, although you should always scrutinate the testicle for abnormal activity or enlargement. However, if both testicles are involved and appear symmetric, this can be difficult to perceive. However, after systemic chemotherapy, you may see all other sites of lymphoma resolve, and you now perceive the testicles that are very hypermetabolic. This is the imaging manifestation of systemic chemotherapy eradicating disease elsewhere, but not in the testicles due to the blood-testis barrier. Appropriate treatment for testicular lymphoma is therefore orchiectomy, most typically. Next, how can colonic adenocarcinoma and lymphoma manifest differently on imaging? If you see colonic bowel wall thickening with obstruction, think colonic adenocarcinoma. If you see bowel wall thickening without obstruction, this could be colonic lymphoma, or less likely something like a fungal infection. The key is that lymphoma typically does not obstruct. For small or large bowel lymphoma, you can see very pronounced thickening or even aneurysmal dilatation of a bowel loop without obstruction. Adenocarcinoma constricts and obstructs the bowel lumen. On MRI, bowel lymphoma would show a T2 mass that is isointense to spleen with delayed enhancement. That is a common feature of lymphoma, regardless of site in the body, that the T2 signal would follow that of spleen, and the area of lymphoma would typically show delayed enhancement. Now I want to circle back quickly to the phrase where I said colonic lymphoma can look like a fungal infection. If you haven't encountered this yet, let me tell you an experience from my residency when on interventional radiology. We did a percutaneous biopsy of the rectosigmoid colon in a man who was presumed to have adenocarcinoma, but biopsies had been negative from colonoscopy. So we went and did a biopsy of the external part of the mass with imaging guidance, and this came back as a fungal infection. Needless to say, the patient was very pleased that he did not have cancer, but had a treatable infection. Next question. What are the top malignant causes of intussusception? Can you think of, let's say, 2 top malignant causes of intussusception? First, lymphoma, and second, melanoma. Those are the 2 top malignant causes of intussusception. So if you see a case of intussusception that has an associated mass, think lymphoma, think melanoma in an adult. Next, what is the significance of the small bowel target sign? The small bowel target sign is the result of bowel wall edema with associated enhancement of both the luminal mucosa on the inside and the external muscularis propria, and this enhancement on both sides of the bowel wall edema gives a target sign appearance. If you see multiple small bowel target signs, think lymphoma or think metastatic melanoma. If you see a single small bowel target sign, think something like a gastrointestinal stromal tumor or GIST, G-I-S-T, primary adenocarcinoma of the bowel, or possibly something like an ectopic pancreatic rest. The importance for now is that the small bowel target sign can be evidence of lymphoma or metastatic melanoma, and these are both the top malignant causes of intussusception. Next question. What is the typical appearance of bowel lymphoma on fluoroscopy? So the dreaded fluoroscopy questions, they actually are high yield on radiology board exams, so definitely no differential diagnoses for various manifestations of the bowel on fluoroscopy. So the typical appearance of bowel lymphoma on fluoroscopy would manifest as multiple thickened folds with nodularity in a segmental or diffuse pattern. A helpful mnemonic for the fluoroscopic appearance of thickened folds with nodularity is male cow, M-A-I-L-C-O-W. If you haven't encountered male cow yet, this is important to memorize for board exams. The M stands for metastasis, A for abscess, I for infection, L for lymphoma, hence this episode, L for lymphoma, C for Crohn's, O for other, such as lymphangiectasis, and W for Whipple's disease. These are all entities that can cause the thickened folds with nodularity appearance in the bowel. Male cow, if you need to review that, download the study guide I will eventually post on my website for lymphoma, www.theradiologyreview.com. And I will release that after I have released all episodes on the podcast for lymphoma. Small bowel lymphoma is rare in the United States. The most common site for small bowel lymphoma is the ileum because that has the most lymphoid tissue, followed by the jejunum and then the duodenum as the less common site for lymphoma of the small bowel. Additional signs of possible small bowel lymphoma include focal circumferential narrowing of the bowel, and again, that may manifest as the target sign without obstruction. Note that mantle cell lymphoma has a characteristic, extremely polypoid appearance of the bowel on fluoroscopy. Okay, mantle cell lymphoma is extremely polypoid. If you have an ileocecal mass causing intussusception, lymphoma and melanoma need to be high on the differential diagnosis. Next, what is benign nodular lymphoid hyperplasia in the bowel, and how does this appear different than lymphoma? So, have you encountered benign nodular lymphoid hyperplasia? If not, let me fill you in very briefly. Benign nodular lymphoid hyperplasia appears as scattered clusters of lymph node follicles that are all of the same size. So essentially you just have scattered small follicles throughout the bowel. They could show this to you from a colonoscopy image. They could show you this to you from a fluoroscopy image. I encourage you to look this up on an image search for benign nodular lymphoid hyperplasia. Now, importantly, benign nodular lymphoid hyperplasia, as the name would suggest, is a reactive benign process that can be seen with entities like IgA deficiency or asthma or infection. Lymphoma would have a larger and more variable appearance of nodules. So benign nodular lymphoid hyperplasia is essentially scattered, similar-sized small nodules. Lymphoma tends to have larger and more variable-sized nodules. Next, what are some common risk factors for small bowel lymphoma? I told you this is rare in the United States, but which patients are most likely to have this? The answer for risk factors for small bowel lymphoma can include things like celiac disease, Crohn's disease, AIDS, and lupus. Those are common risk factors for small bowel lymphoma. Next, true or false? Hashimoto's thyroiditis increases the risk of developing thyroid lymphoma. This is true. Patients with Hashimoto's thyroiditis have an approximately 75% increased risk of developing thyroid non-Hodgkin lymphoma, in addition to also increasing the risk of developing papillary and Hürthle cell neoplasms of the thyroid. Next, is hepatic lymphoma typically primary or secondary? Primary hepatic lymphoma is very rare, and secondary hepatic lymphoma is more common. To briefly review primary hepatic lymphoma, this would present typically with one or more hepatic masses that are hypoechoic on ultrasound and are hypovascular on CT or MRI. The prognosis for primary hepatic lymphoma is very poor. The imaging features of secondary hepatic lymphoma are very variable and can include a miliary disease pattern, an infiltrative disease pattern, or mass-like presentations. For secondary hepatic disease, look for coexisting splenomegaly and lymphadenopathy. For hepatic lymphoma, Hodgkin's disease is slightly more common than non-Hodgkin's disease. Next, Hepatic or splenic lymphoma can present with peliosis. What is peliosis? That is spelled Peliosis. Peliosis is a rare condition that manifests with multiple blood-filled cystic spaces in solid organs, most commonly seen in the liver and spleen. So one more time, peliosis is rare, and it manifests with multiple blood-filled cystic spaces in solid organs, most commonly the liver and spleen. This is another entity that you might want to look up on an image search, peliosis. Causes of peliosis include lymphoma, oral contraceptive use, men on steroids, AIDS, and renal transplantation. Let's call it there for now. Thank you all for listening. Remember that I have many free board education materials. I have suggestions for other free radiology board preparation websites and some other general information that may be helpful to you on my website, theradiologyreview.com. If you haven't done so yet, please follow this podcast on Twitter at RadRevPodcast. I try to send out frequent tweets on hints and advice for radiology board exam questions. Keep up the good work. Study hard. You have to study really hard to succeed on radiology board examinations. Prepare to succeed, and I will catch you on the next episode. Content of this podcast is provided for informal educational purposes only for radiology trainees and radiologists. Medical practitioners, please make your own independent assessment before suggesting a diagnosis or recommending any course of treatment. This podcast should not be used for self-diagnosis or self-treatment and is not a substitute for independent professional medical care. Please consult your own physician regarding any diagnosis, imaging interpretation, or course of treatment.